That's great that I've been told to put this cream on my vulva, or I've been told that I should do pelvic floor exercises, but
I was reading your book last night and how we're not necessarily educated in the right way from the very beginning.
if we can be as informed as possible and just go in and ask the questions, then that's amazing and we can start making big changes.
Welcome to End the Dry Spell, a conversation with leading women's health experts about intimate dryness. I'm Fiona Toomey, the founder of the skincare and wellness brand NAYDAYA. And we're calling on the nation to end the dry spell of awareness and put an end to the stigma around intimate dryness. And we're here to bring matters of moisture into the mainstream. And we really think by normalising discussions about intimate dryness, we believe we can increase its visibility on the women's health agenda. We surveyed over 2,000 women and we got some really interesting results. 83% of women said they experienced intimate dryness at some point in their lives. And nearly 70% of you who suffered from intimate dryness said it affected their sexual relationships. And today we have Clare Bourne, who is a pelvic health physio, and she has got some really good insights and we really hope you enjoy today's episode. So welcome, Clare. And we've worked together for years. You have been a fan of the brand for a very long time. And actually, you are my physio as well.
That's right.
So this is going to get very personal, I think. But just so our viewers know, you are a pelvic health physio with a passion for banishing taboos around pelvic health and really helping women through different stages of life. So would you like to introduce yourself, Clare?
Yeah, absolutely. Well, I think you've summarised it perfectly. I'm a regular physio, but I've gone in to specialise in pelvic health, which really means anything to do with the pelvis, the pelvic floor. Through my own journey of motherhood, I've sort of learned a lot along the way, and I think I'm just really passionate that we keep raising awareness of this, publicly. More people feel they can talk about these topics, and that's why I love what you guys are doing, because you're out there doing the mission.
So Clare, many people think physiotherapist is someone you see when you have a sports injury. Can you tell us a little bit about what you do and what a pelvic health physio does?
Absolutely. Yeah, I think you're absolutely right. So people, when they see me in their clinic, they're like, this isn't quite what I imagined. So really, pelvic health is this specialist area where we're looking after the pelvic region and particularly the pelvic floor muscles. Now, I think a misunderstanding is that the pelvic floor muscles are different to a bicep or a tricep, but actually they are skeletal muscle in the same way. So the principles that we would use for other injuries, we can use to the pelvic floor as well. Now, obviously it's slightly different because it's an examination that we have to do internally. So very different to when we assess a shoulder, where we're just looking at the movement from the outside. In order to check your pelvic floor thoroughly, we have to do an internal examination. So it might feel a bit more like how you would expect a gynecologist to treat you. So that's where I feel like sometimes pelvic health physio feels a bit more medical than it does physio, but really our principles and our training and our understanding of the skeletal system is the same.
Okay. And how did you get into it? Or did you start in pelvic health physio?
Yeah, how did I get there? That's a great question. Most people are like, how did you end up doing this? Well, actually, it was my first ever job as a junior physio. So I actually fell into it sort of by accident because generally speaking, I mean, back then it was just women's health because we didn't even really acknowledge that men or children or those of other genders even had pelvic health. So it was very much female health. And then it's evolved into understanding that actually any human has a pelvis and a pelvic floor, and therefore we should be supporting everyone. So on my first ever day as a physio, they said, oh, you're working in women's health. And I thought, oh no, I don't know anything about this. But I had the most amazing team who mentored me and I absolutely fell in love with it. I did do other areas, but then very kind of early on in my career, I said, no, this is what I want to do. I just loved how important it was and how you made a real difference to quality of life. I love the kind of nitty gritty of life. So I really love talking about taboo things. And here I am, like, over a decade later.
And yeah, it's interesting you say about taboos. Do you think there's still a taboo around pelvic health with women or just with everybody? Or
yeah, I think it's still there. I think we've come a long, long way. Like even in the last 5 years, I think we've come a long way about certain topics. So I feel like incontinence has had a lot of airtime. Yeah. I still think things like prolapse or intercourse conversations are still a little bit more awkward. And I think, as females, we've come a long way. I think in other genders, we've got a long way still to go. But I think ultimately we have to start somewhere. And I think the more we just open up conversations, I work in a specialist bowel team as well. And so, talking about poo is really, really difficult for a lot of us, and bowel symptoms, and lots of women come in being like, I'm just so embarrassed. I've lived with this for years. And actually when we talk about it, I make a joke. I'm like, I've got 2 young kids and I work in a bowel team. All I do is talk about poo. Yeah. You know what I mean? Like kids' humour. I'm like, let's just talk about it. And actually once we start doing it and talking about it in clinic, everyone's like, oh, I feel way more relaxed about this. Yeah. So having those conversations is so important and is the first step to then thinking about how can we make bigger change.
And yet, just interesting about women feeling embarrassed. Do you think a lot of women do feel embarrassed? Do they wait a long time before they seek help, or kind of what happens kind of there?
Yeah, I think, yes, I think there's a lot of embarrassment just like socially. It's very hard to talk to friends about these things. I think especially then if they've gone to seek support and maybe the reception hasn't been positive or hasn't been what really a woman probably needed, or they've been told it's quite normal. And I see this even with my own friendship group. You know, obviously people know what I do. And so I have a lot of friends that come to me and say, you know, I've been struggling with maybe struggles with intercourse, and I've gone here and I've gone here and I've been told this and this. And I'm like, oh, I think we've not supported you in the right way. Yeah. So I think the problem is it's taboo anyway. Then women are trying to reach out and then they're being sort of normalised or not listened to. And then you lose your confidence, right? I would say you've got to put your big girl pants on to go out there and be like, I'm going to go and talk to someone about this. And then if you do and the reception is really negative or not at all what you needed emotionally, you're not going to keep doing that. And I do say to women, you know, lick your wounds, take a minute, try again, because if we don't keep trying and advocating for ourselves, then change will never happen. But I also think there are professionals out there, and I think as physios we get the privilege of time, and generally speaking we get that opportunity to have a wider conversation about it and look at things like women's quality of life. And I think sometimes in medicine we miss that. I think sometimes very much when we're looking at it from a very medical perspective, it's very much like, what's the condition, this is the treatment, job done. And if we've done that, we've done a cream or a medicine, we've done the job. And actually I think we sometimes miss the human side of it, where actually a woman's like, that's great that I've been told to put this cream on my vulva, or I've been told that I should do pelvic floor exercises, but I also don't know, can I have sex if I'm using this cream, or can I have sex if I've got a pessary, or okay, does that mean I can go to the gym or can I not go to the gym? And it's those conversations that are really like quality of life and really what the woman's probably mostly worried about that I think are sometimes missed. And then actually I think that's really what's most important in the whole picture.
And then what different stages do women come to you at? Is it kind of the full range? Do you see women of all different ages, or is it very specific stages like pregnancy, post-pregnancy, menopause?
Yeah, I'd say the most common times are postnatal, menopause. I'm seeing more and more women coming through in pregnancy wanting to be proactive, which I absolutely love. You know, they're like, I'm actually fine and I'd quite like to keep it that way. So what can I do? You know, how do I do pelvic floor exercises correctly? You know, how can I prepare for birth? So always talking about perineal massage. You know, we're always talking about the Victoria, or like, what can we use to help prepare? That's really important. And I think for me, my main passion is we've got to be preventative. Okay, we can't just always be thinking, how do we react when something's gone wrong? Though generally speaking, that's how our healthcare system is set up. Not necessarily a wrong thing. It's very hard to fund constantly prevention. But I do think that's where the wider conversations and brands like yourselves can be doing that work, because actually that is really important. And our healthcare system can't provide everything. So I do see that coming through more and more. But I'm also seeing teenage girls who are struggling. I think mums becoming more aware of, okay, this isn't normal. Let's try and do something about it. But yeah, I mean, I had a lady yesterday in clinic who was 89. Wow. It's never too late, you know? So really the whole age spectrum, anyone is welcome, because pelvic health is not a perinatal problem, which is still, I think, a huge thing that we need to talk about. People are like, oh, I do my pelvic floor exercise for 6 weeks postpartum and then tick. I'm like, but would you ever view that you would exercise any other muscle in your body for 6 weeks and then you're done for life? No, it's a muscle that needs support and training, and the relationship with the tissues and everything like that. It's just a much wider conversation that I think we've still got to keep having.
And is pelvic health just about squeezing? Like, because I think that's what I thought it was. It was just like in, out, done.
Job done.
Yeah.
I think that's how it's understood. But it is much broader than that. So really, in essence, pelvic health is a bit like, you know, mental health. It's a broad term that covers so many symptoms, topics. To break it down very basically, it encompasses your bladder health, your bowel health, your sexual function, you know, and any pain or anything else that you might experience around the pelvis, because obviously the pelvis is a bony structure with a lot of muscles around it. And yes, the pelvic floor is part of that. But really, when we say pelvic floor, within that, you've got pelvic floor muscles, you have sphincters, which are little rings of muscles that are around, say, your urethra, the wee tube, and around your anus. We've also got fascia, which is connective tissue, and we've also got ligaments. So actually there's like a, you know, within each of these things, there's a lot of subcategories where actually that's why pelvic health is so broad, and why, yes, pelvic floor muscle exercises might be part of that conversation. But if we're not thinking about how your bowels are functioning and maybe how you're having, you know, intercourse, and if that's painful, or that's the conversations that need to happen. And that's what I find really amazing to be able to do in clinic, is that, you know, a woman might come to me because she's got problems with intercourse, but when we have the conversation, she's also got constipation and pain every time she does a poo. And then when we link it in to be like, well, of course, if that's painful, your muscles are probably going to protect you, which then might link into how it's responding during intercourse. And you've also had lots of UTIs, and therefore your pelvic floor is behaving a certain way because of that. They're then like, oh, that makes so much sense. And they're literally next to each other, like besties, you know. So I think that's the joined up conversations that we still don't fully understand. And we do think of pelvic health, oh, I've done my pelvic floor exercises here and there. But that's not enough. It's too one-dimensional for really, in reality, what's going on in our body.
So if we talk about intimate dryness for a second, where do you see this pops up at different stages for women?
So most commonly in postnatal women, especially those kind of early weeks and months, or when they are breastfeeding. So generally speaking, when we breastfeed, our hormone levels, estrogen, are suppressed. And so when we have less estrogen, generally speaking, our vaginal tissues and vulval tissues are drier. So that's quite a common time. Generally speaking, once our periods return, whatever time that might be, and we've had around 3 periods, we do start to notice some difference in the tissues, but probably not quite the same until we finish breastfeeding. Then another time, perimenopause, when we've got those very erratic changes in estrogen, and then going into postmenopause. So I say those are the most common times, but I do think, you know, as we've talked about before, changes in our monthly cycle, you know, I think our vulval tissues and our vagina, they are different. You know, when we're ovulating, we have more discharge, and so we can feel very different to maybe just before our period. And so I think for women, it's actually just understanding, well, first of all, what your vulva is, that it's outside and not inside. And, you know, the vagina's inside, the vulva's outside, that it is skin like any other part of our skin. Because I think when women come to me, we might examine and check for things like vulval eczema. I think there's not this understanding that you can have eczema on your vulva, because we view it as a very separate part of our body. Yeah. But just the same as my arm skin, I can have eczema here. I can have eczema on my vulva. So I think it's understanding that that is skin that needs support. And I mean, how many products do we put on our face these days? And yet our vulva, like, good luck, I'm sure you'll be fine. Yeah. So it's just ways that we can, I think, understanding your skin, understanding what's your normal, so you can also monitor for any changes. But yeah, those are the main stages. But I think understanding as well, why do hormones make such a difference? Yeah. So in essence, we have receptors all over our bodies. Our vulva and our vagina have a lot more estrogen receptors. Okay, so when estrogen declines, it impacts those tissues more than it might other parts of our body. And that's why sometimes we have to be even more vigilant of what we do to support our vulva through these different stages of life, even if other parts of our body are fine. So I think it's understanding those basic parts of anatomy of why these things happen, and therefore we can then decide, well, what can we do to support them.
And I was reading your book last night, and I thought there was a really interesting section around education and how we're not necessarily educated in the right way from the very beginning. And so many of these terms, and like even the term the vulva, I feel like has just exploded because it just wasn't part of the education when we were in school. Like, that was the vagina.
Yes.
So how do you think that, I do think it affects women. I do think it affects just everybody the whole way up. Like, do you find people don't know the names of these terms or don't understand what's going on?
Totally. I think we're not even comfortable saying these terms. You know, so many women come in clinic being like, I've got a problem down there. And I'm like, I get what you mean, but can we get a bit more specific? And sometimes I have to say, I'm really sorry, but I'm going to have to ask very specifically. And I can see they feel uncomfortable. And I say, I'm really not trying to make you feel uncomfortable. We've not been brought up to have these conversations. But it's really important. You know, we need to be able to say vulva in the same way that we say elbow or nose. Like, we have to, because it's part of our anatomy. And if you don't know, I think, you know, we've come a long way in saying, I now know what my breasts are like, and I assess them every month so I can track for changes. In essence, we should be doing the same for our vulva. You have to know what's normal. Now, it's so hard being a woman. You can't see it. Like, it's very hard to see. And so you need to get a mirror out. You probably need to have a little look. But if you don't know what's your normal, it's very hard to then assess if there's any changes. And it's really important that we are able to do that, because vulval cancer is a thing, you know, and sometimes it's very hard if we're feeling a bit dry and a bit itchy. Is this something of concern? Is it an infection? Is it skin changes? Is it something, you know, more what we'd call red flaggy? Are we worried about cancer? And so many women come and they're just like, I don't even know what it was like, so I couldn't even tell you. So I think that's why starting young ideally is great, because if girls can start to understand at a very young age, first of all, the names, it's also a safeguarding thing from a kind of abuse element, that if girls and women know their anatomy, they can be more protected as well, and they can also communicate if anything's happened that shouldn't have happened. So it's very important from a safety point of view, but just from their own confidence in their body, knowing what's their normal. I think also knowing that there is a large range of normal, that you will be different to the next person. But I think we have to support girls to do this because it's just not the same as for male anatomy.
No. So we all need to get a mirror and check.
Just have a
our
check.
vulvas, check around, and then track it. Like
Absolutely.
you would your boobs.
Exactly. As you would a mole, as you would any other part of your anatomy. But, you know, I wasn't educated in what these things was. I don't think most of us were. And I always say to women is there's no shame in not knowing at all. At all, you know, women come and they're sometimes like, am I meant to have 3 holes? I can't find the 3rd hole. And I'm like, let's get a mirror. Let's talk about this because that has to be step 1 in anything for me. There has to be education and understanding of your body, and then we can go from there. But if we haven't got that, really everything else is irrelevant because you can't apply it because you don't know what you're really talking about.
Yeah. So Claire, you're obviously my physio, which I love. So it's great to have you here on the couch. So I felt like in my life, I've had different bouts of intimate dryness. So one was after having a baby. Once I got contract dermatitis from the Nuvo ring, and then now I'm entering perimenopause. So it's like really fluctuated. But I went to you kind of for lots of different reasons, but it wasn't something I mentioned. Like, do you feel like there's a disconnect of intimate dryness and maybe some other problems that women are having, or where do you think women kind of sit there?
Yeah, absolutely. I think we don't even really realise it's a thing, you know, as we talked about those kind of hormonal changes, like if we're not even really aware that we have these different receptors and that dryness can happen, it's not, I think once someone says to you, do you feel a bit dry down there? You're like, hang on a second, yeah, I do actually. But we don't really connect because I think we're not expecting it, because actually, why would you if you're not even aware that could be a thing? But yeah, when we have, I mean, it's very much related to the hormonal changes and then how this causes changes in the tissues. And that can cause a broad range of symptoms. So it might feel more itchy, more dry. The intercourse is less comfortable or less pleasurable, or you're thinking, I have to use way more lube than I used to. It can be these more subtle things that you don't even necessarily link together. But it can also relate to, say, if you've got an existing prolapse, you might start becoming a bit more symptomatic. Now, essentially, when our tissues have less estrogen, and as they say, this happens not in all stages, but at different stages of life, the tissues can be, well, they're drier, they're a bit thinner, and they're more sensitive. So even though our prolapse may not have progressed, we may experience and feel it differently. So sometimes using sort of, you know, a moisturiser internally or one on the outside can also change our symptoms. Now, I think sometimes we do have to get women to use a vaginal estrogen, but I always say, you know, I don't think it's like a one size fits all. So I might get someone using a vaginal estrogen so we can get more estrogen into those tissues, and those receptors are like, thank you. But then we also might say, well, let's also use an oil to support the vulva from the outside. You can get in different cream. There's so many different things. And so I think it's a huge topic that I often go into with a lot of women, but you're absolutely right. They don't come in saying, my vulva feels dry or my vagina feels dry. But when you talk about it, they're like, oh, that is actually what I'm feeling. And then we try and link up the dots as to what they're experiencing and how this might be relevant as part of then this wider picture of helping them to feel better.
And the estrogen thing is interesting because it's my perception that estrogen would be offered to women in later stage, so maybe in perimenopause. But what about the women before? So, you know, I had really bad dryness after I had a baby, and yes, that did correct itself after a while. But then there's different periods that women can go through. So what can they do? Because you're not going to be throwing out an estrogen cream to someone in their 20s. I don't think. I don't know. Maybe I'm wrong.
Generally speaking, no, unless there is something actively that we're treating. But definitely, it's tricky because I think we know it helps. And say if we speak about the postnatal community. So some women who are, you know, they've got particularly dry tissues, or they've got a wound that's been particularly uncomfortable, or scar tissue, or a prolapse, then some clinicians will prescribe estrogen at that stage of life. And it is something that we can use. Now, the struggle that we always have is guidelines, and do we have enough research and stuff? So it needs to be a very specialist person who's making that decision and conversation, because anytime we put hormones in the body, it's a wider conversation. So I think women, it's definitely a conversation to have, and it can be used postpartum. Yes, most commonly, any estrogen is used, you know, through perimenopause, maybe postmenopause. But I think when it comes to vaginal estrogen, women need to understand this is different to, say, a patch or a gel or anything else that you might use that is an estrogen. And you can use kind of what we'd call systemic HRT that's going through your body that might treat more things like hot flushes and those kind of brain foggy symptoms, as well as using a vaginal estrogen. So you can use both, or you could just, if you've just got mainly vaginal symptoms, you can just use a vaginal estrogen, or you can just have systemic estrogen. But there's this, like, this is where it has to be a really, you know, proper consultation where those conversations are had. But women don't even know it's an option. So when women come in and I'm like, I really think some vaginal estrogen could change your life, it honestly often does change their life. But again, they might also want to still use other products to help the skin and the tissues as well.
And what are some of the misconceptions around intimate dryness, do you think?
That I think we have to put up with it and it's just normal, that it's not anything that can be helped. It's just stage of life and that's just what we have to put up with. And that's just not true. Again, as relating to our face, would we just put up with, well, I've just got a dry face and there's nothing I'm going to do? No. And I think another conversation is, if we had any other skin conditions, we would go to a dermatologist, right? Now you have dermatologists, you have specialist interest in the vulva. Now, this is something that most women have never heard about. You get vulval dermatologists. So I work with some really closely who, if we've got any concerns around the skin there, yes, it may, if it's just kind of general, what we'd call atrophy, when there's less estrogen or it's a bit dry at these different stages of life, we might treat it through the GP and have a bit of support that way. But if there's any other conditions, maybe lichen sclerosis or planus or these other dermatological conditions like eczema, we need a specialist who understands the vulva in its complexity. So again, I think there's this misconception that there's nothing that we can do. And I think the problem is that the wider medical community don't necessarily know about these specialists, and that's not their fault. I think we can get very blame focused. I don't think it's anyone's fault. These are conversations that generally haven't been there, so they're not been part of training, and therefore, and it snowballs. But I think as women, if we can be as informed as possible and just go in and ask the questions, then that's amazing, and we can start making big changes.
And do you think there's a mind and body connection between kind of vulva problems, intimate dryness? How do you find women kind of, do they get extra support? Can they get extra support? Because it can really affect, your sex life. It can just if you feel disconnected, I think, with how you're feeling.
Totally. I mean, I think this within the broader pelvic health conversation, there is such a connection with our mental health. And we know quite a lot of that around kind of topics like prolapse, but in essence, as you say, it's all connected. Yeah, absolutely. If you're feeling very uncomfortable in your vulva, or you don't know what's going on, or it's itchy or it's sore, and it's very all-consuming. We have a lot of nerve endings in our vulva for good reason, for our pleasure, and that's amazing. But that can also then flip on the other way, and you can be incredibly aware of it if it's very uncomfortable and sore. And something that's very small in the vulva might feel huge, whereas if that same, say, cut or something was on your arm, you may not think about it in the same way. So the way we sometimes say to women after birth, it's just a graze. A graze in your labia or your vulva is very different to a graze on your knee.
It is, I know.
Right. Been there, done that.
Been there, done that.
When they're like,
Lots
it's just a graze, you're like, oh, just a graze. And then you do a wee and you're like, it's like shards of glass, So I think, again, it's understanding that things down there do feel very different to other parts of our body. So, I think, there's so many bits to it, but the mind and body is another massive conversation that women need to understand more of. Anytime we talk about intimacy or intercourse, I always say to women, this is not just a physical thing. So, but equally, it's not just in your head, but it's understanding that there is a constant relationship. And then you bring in another person into that conversation, and then that's a whole nother dynamic. So yes, absolutely, feeling disconnected from your vulva, or just thinking like, I don't like it down there, or I'm very anxious about it, or etc., is going to come into your intimacy and your relationship with someone else, because you're not going to be as relaxed. When we're not as relaxed, then we're not going to enjoy it as much. We may not feel as aroused, and it's then that vicious cycle. So definitely a huge important thing, and it's something I will definitely talk about a lot in clinic, and we have these amazing psychosexual therapists who also help with that regard. So it's very important that we work together and work as a team to support, to understand that. And that's where really this side of physio is so different to say if you've got a shoulder problem, because it's just not, say, as layered potentially as when it comes to our vulva.
And then if we talk about exercise, because obviously, you're dealing with women at different stages, like if they are suffering from intimate dryness or different pelvic health problems, like I'm sure it's not one size fits all, but can they exercise? Like what can they do? I mean, I know when I had a grazed vulva, I was like, it's very unpleasant. So what do you do? How do you advise women?
Yeah, so definitely exercise is really important. I think if you break it down into different things, so doing pelvic floor exercises, if you've, we've even through perimenopause, postmenopausal, we know that movement of the muscle brings blood flow. This can help with tissue elasticity, and it can improve our kind of just how the tissues feel as well. So moving those muscles is good for the tissues as well as the muscles. So I think that's the kind of first step. Then the wider conversation around exercise is, really helpful. I mean, if you've got vulval conditions, things like sitting on a bike or a saddle can be really awful and uncomfortable, which again, we don't really talk about. Equally, things like tight leggings, all of us are wearing these very tight leggings, and that can cause a lot of discomfort or not a lot of airflow to the vulva, which also cannot be great as well. So I think absolutely fine to exercise, but if it's making your symptoms worse, again, we need to think about how we change that and what we need to put in place. But generally speaking, exercise is great for so many things, and our pelvic floor and our pelvis love it when we move, but we might struggle at different times, particularly with intercourse or prolapse symptoms, through higher impact exercise. Now, it doesn't mean it's off the table forever, but we might need to grade up to it. And again, that's where proper rehab and not just squeezes here and there is needed, in the same way that you'd never treat a knee injury with a few kind of movements of your knee up and down and then think that a marathon would work. You have to do a graded program, and unfortunately I think generally speaking that's not how we understand the pelvic floor muscles.
So we surveyed over 2,000 women around intimate dryness, and we found that 36% of women did not feel supported by their healthcare professionals when they asked for help around intimate dryness. So how can we make sure these women are getting the support, and where do they go to get the support? Where do they know?
It's heartbreaking, isn't it? I'm actually surprised it's that low. I feel like potentially it could be even higher if we surveyed even more women. It's really hard. I think it's just a wider systemic problem, which I think, if I'm honest, we have to start, grassroots, again, within medicine, how we train our doctors, how we have those conversations. Even like physiotherapy degrees, getting more pelvic health knowledge in there, because the more professionals know about it, the more women are going to be able to do it, come and have conversations and us make some changes. I do think, though, while that's happening, and that's going to take years to happen, I think as women having conversations with our friends together, supporting each other, opening up and looking at how we can feel like we can advocate for ourselves, writing things down, going into consultations, having done a bit of research ourselves, maybe knowing that, like listening to podcasts like this, knowing that there's an option for vaginal estrogen, that you can even ask that as a question, be proactive, things like get your victory oil, use it and try it, and say, because sometimes it's really helpful to go to a doctor being like, I'm really struggling with intimate dryness. I've actually tried this oil. It's helped a lot, but I'm still struggling with intercourse. And it shows that you've done a lot already, but you maybe need a bit more support. I think the other thing I'd always say to people is, if you're going through your GP, which most of us would do within the UK, within the NHS, is look on your GP website and look for anybody that's maybe got a specialist interest in women's health. Now, this may look like after their name, they may have like something like DIP, RCOG, like a diploma from the Royal College of Obs and Gynae. The chances are they are going to have more understanding of things relating to the vulva and the vagina and intimate dryness than somebody else. And that's what I often do for women, is I help them navigate how to find the right person to give them the right support. It absolutely is there. And it's heartbreaking that I think we hear so many stories where the support isn't there. But even nowadays, if you're in the perimenopause or postmenopausal, you can buy vaginal estrogen over the counter. Yes, you need to go through some understanding of what that is and fill out a pro forma. But I think the accessibility is improving. But the conversations still need to happen, and we've got to be having them on kind of a level of women to women, as well as then supporting us to kind of navigate the system.
Yeah, because I know even before I came to you just more recently, I was like, where do I go? And I'm in this business. I'm talking about it all the time. But I was like, I don't want to go to my GP. It's like, he's a 60-year-old man. I don't want to talk to him about my problems. So I was like, texted you, okay, Claire, where should I go? But it's still like, I still think there is a problem of women just don't know where to go and maybe don't feel comfortable talking to certain people. So I think that's really good advice of, looking up maybe doctors, GPs that have that speciality, because I think that is a bit of a, because that is GPs are the first people we would normally go to.
Absolutely. And I think, yes, they are general practitioners, but generally speaking, they all have quite specialist interests. And what's happening now, I'm married to an NHS GP, so this is how I have some inside knowledge, is that you're getting more and more who will have a specialist interest. So if someone's coming in and they've got a problem with something related to their ears, their nose or throat, or a paediatric problem, then they will start being linked into someone who's got more training in that area, because doctors are always learning and they're always doing more courses and more qualifications. So I think it's feeling like sometimes I think we feel like this is my GP and I have to go to them and them only. But actually, in the same way that you would do with any other problem. And I think where we're going within medicine is that GPs are becoming more like hubs. So you've got kind of more professionals within there that we can then start triaging and streamlining into more specialist services. Now, that's not always widely known, and I don't think equally those conversations. And a lot of the time, women haven't been to the GP that much. Maybe they felt really healthy and well, and there's never been a problem. And then they start to have these symptoms, and they're like, oh, again, where do I go? Is this a GP problem? Now, ultimately, GPs should really be able to consult on a lot of things and then signpost, but it depends on their specialist interest and their training, and that's not necessarily their fault. And I think we can support them in their awareness of what's available out there, even just what is pelvic health physiotherapy that is even available, but yes, physios, I think we sometimes are able to support. Now, again, it becomes complex if you're going private or NHS, but I think the support is absolutely there. There's tons more resources online. There's books. You guys have loads of free resources. So I think it's just, even if say a friend text a friend and they're like, oh, I heard this podcast or I read this thing, or you share it, you start to educate yourself a bit more, and that's how things will change for you.
And actually, so menopause, like perimenopause, I think that's another area where women struggle on where to go, because there's a lot of GPs that don't have that speciality, and it is something that all women go through. And I've got friends texting me like, where do I go, this is happening, and it is so hard, and they might go to the GP and they might be like, okay, I don't know, they just say no, like you're not ready for HRT, so where do they go?
Yeah, no, it's really hard. I think where we're going is we're going to start having sort of what we call menopause champions, hopefully, in each area. I think where we're at the minute is, and this happens often a lot, is that we have these campaigns, women's awareness increases, but unfortunately our structure and infrastructure of healthcare hasn't quite caught up yet. Yeah. And I see that a lot with pelvic health. I think a lot of women are really aware now that they need more pelvic health support, and sadly we just haven't quite got the NHS support there. So I think what I'd always say to people is definitely we should be thinking NHS first. If you've had a bad experience with one GP, again, look on the website, see if maybe there's someone else, because there may be someone else in the same practice. And I know this happens because I see it happen in clinic. I say to women, right, you've tried with this person, I'm going to write a letter to this person, advocate, support, and they get the right support. So it is possible. So don't, just because one person has said no, think, well, that's it, that's me done. Try again, just do a little bit more research to see what you can find. I also think there is definitely more of an option to hybrid between a bit of NHS and private. So sometimes you may choose, you say, okay, actually, I'm really, really struggling. I'm going to invest in one private, maybe menopause consultation with a specialist GP who might be then able to then say, actually, I can write to your NHS GP and maybe they can do a few blood tests, or they might then prescribe the stuff for you. So I definitely see people doing a bit of that, especially also within pelvic health. Some people come to me because they're struggling to know how to navigate and where to go. And then I try and support them getting into NHS services. So I think you often can feel it has to be this or it has to be this, but I definitely think there's more hybrid approach that we can do. Or yes, there is the option, if you financially are able to, or maybe you have insurance, to go fully private. But I think there are different layers and tiers. Ultimately, yes, we need more GPs to be menopause champions and coming through to support that. And I think that is a lot of work going on behind the scenes. But yes, at the minute, I do think it's not there enough. But it's just trying and keeping going, really, until the help is there.
So what would be your biggest tip for women going through menopause or post-menopause? Because we have so many customers in this stage. So what would be your biggest tip?
Yeah, I think know that vaginal dryness and multitude of symptoms that can go with vulva are, very expected, but they don't have to be put up as that's just another part of menopause. I've got to accept that there is support. Pelvic floor exercise is going to be wonderful for you. So even if you don't have symptoms, get on with that. Use a vaginal moisturizer, use a vulval oil, look after that area, invest in that area in the same way maybe you are in other parts of your body, because you won't regret it and it will make your whole life feel a lot better.
Thank you so much for coming today. I feel like I've learned so much, and I feel like it's been a really digestible conversation. So I'm hoping people will get something from it. And I just want to say thank you so much. I will see you in clinic soon. And just for everyone that's watching, if you enjoyed today's podcast, please give us a follow. We're doing an amazing campaign called End the Dry Spell, and you can check out our website and find out more.